Okay, so this is a patient who had a history of kidney transplantation, and this is a urine specimen from a 53-year-old female. So it is very important that we know that the patient had a history of transplantation in the beginning. If you check the requisition sheet, there is a ICD-10 code is Z94, which means that the patient had transplantation of the kidney. So in the clinical setting like this, it is important that we don't misinterpret of these polyoma virus infected cells than the high-grade urothelial carcinoma. So this cell is called decoy cell, and because it is a mimicker of the high-grade urothelial carcinoma. The resemblance between these two conditions is first that they both have very high NC ratio. And on a medium power, you can tell that the chromatin pattern is sort of like hyperchromasia, but when you take higher power, you can see the nucleus is actually more ground glass, and you can see chromatin material margination at the periphery of the cells. So again, this is also a typical decoy cell. So the nucleus will be enlarged, the NC ratio would increase, there will be some hyperchromatic pattern, but the detail of the chromatin is very different. So it is most common occur in patients with immunocompromised conditions such as transplantation or under chemotherapy or under immunosuppressant for example, autoimmune disease. Rarely we may see occasional like viral inclusion like cells in patient relatively healthy, but most commonly in elder patient that can be a subclinical infection. So we only report these in patient with condition like particularly kidney transplantation, and rarely in the chemotherapy condition because it may be related to the adjacent of medication. But for the healthy patient, we don't need to report it. We don't even need to report that we see a typical cell, because if we recognize these as viral inclusion due to these ground glass appearance of the chromatin, we don't need to call it atypical. We should call it negative. So this is called negative instead of atypical. So let's move to the so the next specimen, the patient had the past history of pancreatic cancer, and he had multiple ascites in our hospital, so we've called these positive for carcinoma before in the ascites. In this specimen, the cancer cell is very, very scant. You see mostly mesothelial cell and inflammatory cells. There is one very strange looking cells with abundant but vacuolating cytoplasm. And if you take a detailed look of the nucleus, these two nucleus looks very different in size and shape. So this is compatible with a metastatic adenocarcinoma. But the lesional cell is very, very scant. For this cell, it is a little bit uncertain if it is a carcinoma or it can be a enlarged reactive cell. So for this cell, it's very difficult to tell. If we see only these, we call it a typical. I think most of the cells are atypical looking. The most definite cell would be the single cluster of this very large cell. But because he already had multiple positive ascites, so it is okay that we just call it positive adenocarcinoma in this specimen as well. So the next specimen is from a patient with non-history of cholangiocarcinoma, and this is also an ascites specimen. In this specimen, it's much easier because you can see on low power, we already see a lot of larger cohesive cluster of atypical cells. And when we go to higher power, you can easily appreciate that typical appearance of the nucleus. So these nuclei show vesicular chromatin and multiple distinct like chromocenter or nucleolus, and with very strange shape or size. And the size of the nucleus are variable, with smaller and larger one. In one cluster, it already exceeding the 4 times of the size of the adjacent nucleus. So this is compatible with positive cytology for the ascites, and it is compatible with adenocarcinoma. And you see a mitosis over here. So the next specimen, the patient had a history of endometrial cancer. The cancer type is carcinosarcoma, and this is an ascites specimen. In this specimen, we only see the adenocarcinoma component manifesting as a like tight cluster of cell ball with similar appearance of the prior specimen, vesicular nucleus, and the variation of the size and shape. And we also see prominent nucleolus in this specimen as well. So if we go to the more flattened area, such as these, you can see prominent nucleolus. So this is compatible with adenocarcinoma. And we didn't see any sarcomatous component in the specimen. It is also quite rare that we see sarcomatous element in the body fluid specimen. So the next specimen is a pleural effusion specimen. The patient had a past history of breast cancer. So the breast ductal carcinoma it's quite common that we see in the pleural effusion specimen. Most of the time we will see either cell ball or Indian fire arrangement. In this specimen, it appears that the patient might be under treatment, so we see a lot of necrotic debris in the background. Some of the necrotic element will show bright oranginophilic like staining, so please do not mistaken these as a squamous cell carcinoma, because sometimes in the necrotic debris you will see this oranginophilic material, but it does not represent keratin. So again, here is a degenerative cell with oranginophilic staining, but it does not necessarily correlate with keratinized cells. So most of the cells still show similar appearance. For the breast cancer, usually the hyperchromasia is more apparent compared to the other adenocarcinoma. So sometimes it will give it a little bit of squamoid like appearance. But again, we do see prominent nucleolus and glandular arrangement. So this is compatible with breast cancer, but with massive tumor necrosis. So the next specimen is a fine needle aspiration specimen. from thyroid. So this is a liquid-based preparation specimen. On low power, we don't see any colloid. We only see very tight but scattered cluster of cells. So the cellularity is not very high. So when we go to higher power, these tight cluster, you can see there are some vague microfollicular arrangement. So again, these very tiny cluster, you do see plain-looking follicular cells arranged in a vague microfollicular pattern. So the differential diagnosis of these would be adenomatous nodule from a multinodal goiter, or it can be a follicular neoplasm. So with low cellularity, but definite microfollicular growth pattern, we usually would diagnose these as AUS, atypical atypia with undetermined significance, and we would address that we see architectural atypia. If the cellularity is higher, like what we see yesterday, we would call these suspicious for neoplasm, or suspicious for follicular neoplasm. So the next specimen is also a thyroid specimen. So on low power, again, we don't see a lot of colloid. We see scant, like a thick colloid, dense colloid, and that's it. We can see a multinucleated giant cell over here. And the cellularity is higher than the prior specimen. So we see a little bit of colloid, we see multinucleated giant cell, so we think about that. Could it be a papillary thyroid carcinoma? So we go to the higher power and we can tell that the nuclear appearance is very different from the prior specimen. Instead of like small rounded cells with uniform size and shape, so these ones show more like oval, irregular nuclear pattern and with frequent nuclear groove. And there are some clearing area in the nucleus as well. So we also see like a more three-dimensional fragment and with branching appearance and the central core. So this is a papillary fragment. So architecturally, we do see papilla. Here is a decapitated papilla that we see. There is a luminal border at the one side of the cell cluster. The other side is the decapitated section. So we see giant cell, we see papillary growth pattern, and we go to high power. We do appreciate that PTC nuclear feature in most of the cells. So this is positive for papillary thyroid carcinoma. Sometimes it's a little bit difficult to find the pseudo inclusion, but luckily we have a second case which also show typical appearance of papillary thyroid carcinoma. So here you see irregular nuclear membrane, elongation, and with a lot of grooves. Again, similar appearance. So on low power, we just see hypercellularity, and we do see monolayer of tumor cell as well as papillary tumor cell. Again, when I try to find pseudo inclusion, it is not like a right away you can see. Let's see the dotted area. Okay, here you might see one of these very tiny pseudo inclusion. Here is also one over here, another one over here. So this is also typical for papillary thyroid carcinoma. So the clue would be hypercellularity, and you see papillary growth pattern with a fibrovascular core, and we see monolayer flattened sheets with background of scant colloid. So this is very typical for papillary thyroid carcinoma. So finally is the pap smear. This is a 77-year-old female, so relatively old. So we will usually not screen for cervical cancer in the age of 77-year-old. Comparing to the other elder female, the specimen is not very atrophic, I would say, but we do see scant cells with increased nucleus size and sort of like a multinucleation and hyperchromasia. So this is a little bit strange. We tend not to overcall a typical squamous lesion in elder female because it's the statistically it is not likely to have precursor at this age. But still, we do have multinucleation, hyperchromasia, enlarge of the cells with relatively low NC ratio. So I think the cell itself do qualify that we call a typical squamous cell, ascus. So for these specimen, we decided to call it ascus. There were not only just a few area, but also some area like these as well. So I think we need to call it ascus. So this has been called ascus. Okay, that's all the case for today. Thank you.